The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.
Okay. Hello, good day, dear listeners. We are happy to present the June edition of our webinar series from the Limi Children's Hospital. We are happy you are joining us today. The Limi Hospitals is a group of 3 hospitals with our headquarters in Central Business District, the Limi Multi-Specialty Hospital. We also have the Cardiovascular Center, the Cardio Care Multi-Specialty Hospital located in Area 11, Gariki. Now, for today, the Limi Children's Hospital is making the broadcast of an interesting topic today, and we are so confident that you will have value for the time spent listening to us. So the Limi Children's Hospital is a designated specialty hospital for pediatrics. So we have our strengths in general pediatrics, pediatric cardiology, pediatric neurology, neonatology, and adolescent medicine. Now we have a drive. We believe that a healthy child is a happy child, and a happy child makes for a happy home. So we want to make sure that homes, families are happy by making sure children are happy. Wow. So in today's episode of our webinar, we are presenting the topic titled Management of Syncopal Attacks in Pediatrics. Syncopal attacks occur across all age groups, and some are, so we know that it's quite common, but we're not talking about any recent history of syncopal attacks that our audience will know. We're just talking about pediatrics, right? Childhood and adolescence. I am Dr. Igoche Peter, and with me today is...
I'm Dr. Zainab.
Fine. Yeah, so we go straight. So what are our learning objectives?
So by the end of this presentation, we expect our listeners to be able to identify syncopal events, diagnose some syncope that transcends complete loss of consciousness, and they should be able to identify it and differentiate it from its differentials. And also,
Yeah, so we'll also pay some attention to the physiologic basis. We are going to make sure it's very simplified, right? And so because they are different, they have different mechanisms. So the pathophysiologic basis of the various types of syncopes will be simplified. I think that's one thing that we want to be sure that our listeners get very, very easy today. Yeah, so we have a case.
okay, so this is a case summary we saw in Limi Children's Hospital. It was a 15-year-old male boarding school student who presented with history of recurrent frontal headaches, and he was treated for peri-meningitis in a different facility. Although the cranial MRI came back normal, he had a fainting spell. That was the first ever he had experienced in his life. A day prior to presentation while standing, and it was said to be preceded by dizziness with background occasional sharp left anterior pneumothorax pain lasting less than 3 minutes. We could not establish history of sedative or stimulant intake, but
it was vague. We couldn't separate from his parents. We couldn't push too far. We couldn't get that.
Yes, and then further history also revealed that he did not like his school because he was experiencing some bullying. So, physical examination that was conducted on the case study, the CVS exam was done while supine and while standing for comparison, and while supine for 5 minutes, pulse rate was 94 beats per minute. It was regular. Blood pressure on the right arm was 178 millimeters of mercury, and while standing, pulse rate was 104 beats per minute, and blood pressure was 100 over 70 millimeters of mercury.
Yeah.
So with the observations made while conducting this physical examination, the child did complain of feeling dizzy while standing, although there was no syncopal attack, and then apex beats and heart sounds were normal. Also, respiratory exam and CNS examination revealed normal findings.
Yeah, so we did some investigations and it happened that they were all normal. We did an ECG, it was normal sinus rhythm, echocardiography was done, it was normal study, the electroencephalogram, generalized beta activity, which is usually normal, except maybe the child was on stimulants, which we couldn't get. So we have this case that has been presented. We deliberately presented this real life situation for today, and we want to ask, assuming you meet this child, that's talking to our audience now, what can you make out of this real case? The mother was very, very anxious. All right, so we will start our presentation by defining what syncope is.
By way of introduction, syncope is a symptom rather than a diagnosis itself, and it is an abrupt, transient, complete loss of consciousness.
Yeah, so we have like 4 things. It's abrupt, it's transient, it's complete, and there is loss of consciousness.
Yes. Also associated with the inability to maintain postural tone, and recovery is spontaneous without any intervention.
Yeah. Okay, fine. So if we are dealing with a transient complete loss of consciousness, it's not only syncope that will cause loss of consciousness, it's not only syncope that will have that which is transient. So we have other differentials. There is usually this need to differentiate between syncopal attacks and seizures. While it will become clearer during the presentation, we want to quickly say that a syncopal attack may have some abnormal twitching after the loss of consciousness. Now, this is different from post-ictal state in actual convulsions. We remember that there is hypoxia because there is hypoperfusion to the brain. But in syncopal attacks, the response is hypoxia of the brainstem, whereas in seizures, it's actually the abnormal firing from the cortical neurons. So they are different. So after seizures, the patient could have post-ictal state, which will be longer, whereas this would just be a mild twitching. So there are other psychogenic non-epileptic seizures and some rarer conditions like transient ischemic attacks, which is vascular, subarachnoid hemorrhage, even breath-holding spells can also manifest as transient, and this must be differentiated from syncopal attacks. All right. Okay.
The epidemiology of syncope varies, but by the time 15% of children reach the end of their adolescence, about 15% of them would have experienced syncope. There's a female predominance to male, and the syncopal attacks usually in children are benign. That is the less sinister causes, although there can be cardiac causes of syncope also in children. So detecting that is...
Yeah, so it becomes important. So if most syncopal attacks are of the reflex syncope variant, which is benign, one, we want to, towards the end of the presentation, we'll talk about complications of syncope. We want to prevent it, that's one. We also want to be able to identify, is this benign or is this possibly fatal? Is there something we can do to prevent it? So that's why we are making this presentation. Cool.
So in simplified terms, syncope can be classified as non-cardiac and cardiac.
Yes, yes. So fine.
As we proceed, the non-cardiac causes of syncope, those are the benign ones.
Yeah.
We have reflex syncope, and under reflex syncope, we have vasovagal syncope, situational syncope, which could be due to micturition, coughing.
Yeah. So there are clear-cut events, physiologic events that it is associated with.
Yeah.
So someone goes to micturate and has a syncope. Yeah. So situational syncope.
And then we also have the carotid sinus syncope. Then
yeah, so like a carotid sinus massage, anything that causes a pressure on the carotid sinus, yeah, can trigger the reflex syncope in such people. But it's clear either the tie is too tight or there's pressure on the neck and the person can have a syncopal attack. Yes.
Then we have orthostatic syncope, which can be due to volume depletion.
Yeah, so for children, maybe like acute diarrhea disease, hemorrhage, whatever causes blood loss, right? Yeah, and also vasodilators. And the thing is that the venous return is less, either because the total circulating blood volume is less as in volume depletion, or the capacitance of the vessel. So there's a dilatation. So it's dilated and there's a downward pulling due to gravity, and so venous return is less. In that case, it can be orthostatic syncope. Also in autonomic failure, where there's problem with the innervation, yeah, they could have syncope of the orthostatic variant also. Now, we have highlighted reflex syncope, orthostatic syncope, but there are other ones also, right?
Yes.
Yeah.
We have syncope that could occur due to systemic illnesses like hypoglycemia, anemia, and dehydration.
Yeah.
We also have drug-related syncope from drugs of abuse.
Yeah, so drugs of abuse. So drug history is very important for any adolescent in particular, right? Even children on regular medications, yeah, but drugs of abuse are commoner among adolescents, right? Yeah. So beta blockers like antihypertensives, reducing the blood, can also cause orthostatic hypertension, and all these, yes, as we have mentioned. So we have an overview of the syncopal mechanisms. dear listeners, want us to just pay attention to this. If we pick these 3 bullet points, then we can understand every other thing we are talking about. So slide number 13 is very, very important. Now, reflex syncope, usually there is an event, maybe like phobia, anxiety. So this is like that sends a message from the brain, that's on the brainstem now, with vagus overdrive to the cardiovascular system to cause syncope. So it's identifiable, something, a trigger that will send impulse from the brain, which we will see as we progress. We'll send trigger that will send impulse from the brain through the vagus nerve, parasympathetic innervation, to the cardiovascular system. Whereas in orthostatic and cardiogenic, the message is coming from the cardiovascular system to the brain. So in orthostatic syncope, generally, there's decreased venous return. We said either because there's volume depletion or there is increased dilatation of the vessels, right, of the venular dilatation, or there is a problem with the innervation, right? So when there is decreased venous return, that impulse is sent from the cardiovascular system to the brain. The person gets an orthostatic syncope. Now, cardiogenic, we have a lot of causes, etiology of cardiogenic syncope, but the underlying factor there is that there's decreased cardiac output in all of them. So the central nervous system picks the decreased cardiac output, sends impulse to the brain, and the cycle is triggered. So if we can understand this, we will refer to it as we progress, so that all the variants of syncope become very, very clear.
So understanding the pathophysiology of any type of syncope, we'll start with reflex syncope, is important in this presentation in order to differentiate it from the different types.
Yeah.
So for reflex syncope, it is a parasympathetic overdrive firing at the sinoatrial and atrioventricular nodes of the heart, decreasing the heart rate, in turn decreasing the systolic blood pressure. And then
so in this case, so we know that sympathetic activity is positively chronotropic, that increases heart rate, and we know that increased parasympathetic activity is negatively chronotropic, so reduces heart rate.
Yes.
Now, the vagal impulse affects the sinoatrial node, which is the center of automaticity of the brain. That's the most excitable tissue in the conducting system. So it dampens its automaticity. And then it also affects the AV node, lengthening the AV nodal delay. So in the long run, there is a drop in heart rate. So this is called cardio-inhibitory effect.
Yes.
Yeah, because heart rate and stroke volume, they are necessary to get blood pressure. If heart rate drops, the parameter in blood pressure is also the systolic blood pressure drops. Now, sympathetic and parasympathetic will be working in opposite directions, right? So the parasympathetic has caused a cardio-inhibitory effect by firing. Now, the decreased sympathetic activity. Now, sympathetic activity is necessary for increased vascular tone for constriction, but it drops. So there is decreased vascular tone, that's the arteriolar and venular level. So therefore, if the tone is decreased, the capacitance vessels have dilated, venous return is less, preload is less, overall total peripheral vascular resistance is less, so diastolic blood pressure reduces. So there is a stimuli we shall see, like phobia, people who have fear of heights, right? There is phobia, there is one bad news that somebody hears, that is a stimuli. That stimuli fires the vagus nerve and dampens the sympathetic activity. Yeah. So when we have systolic blood pressure decreased, diastolic blood pressure decreased, automatically circulation is reduced and the brain picks it up first because of decreased cerebral perfusion. When cerebral perfusion is decreased, there's total transient loss of consciousness, which is syncope. So this is the mechanism that causes reflex syncope, of which Vasovagal syncope is one of it. If you are talking of vasovagal like phobia, situational syncope, you are talking of triggers like micturition or carotid sinus syncope, where you are talking of a massage on the carotid sinus. Good. So of the reflex syncopes, vasovagal is the commonest. Yeah.
In otherwise healthy children.
In otherwise healthy children,
And
yes.
adolescents.
Yeah, yeah.
Yes. So vasovagal syncope is distinct from the other type of reflex syncope in that it has a prodrome, intra-event, and the post-event findings.
Yes.
So prodrome symptoms are usually feeling of lightheadedness, hypoperfusion. Due to hypoperfusion, they start having tinnitus, profuse sweating, and other feelings like nausea. And then intra-event.
Okay, so this prodrome is very important because part of our objective is to, so I know we've been able to make our audience understand what syncope is, right? Total, that's transient loss of consciousness. Well, fainting in plain language, right? Now, the faintings, the syncopes have different characteristics. So prodrome is almost classical in vasovagal syncope. Prodrome is very important. It's so much that if it repeats, the patient gets to know the warning signs. So prodromes are also called pre-syncope. So the patient gets to know these signs that, oh, I am beginning to feel lightheaded, feeling like I'm dizzy, or there is a visual prodrome like a sudden blanking out, because the hypoperfusion also is picked in the retina. So retinal hypoperfusion, and the person has that blanking out. So prodrome is very important. Prodrome is absent in cardiogenic syncope, right? And it may or may be present in orthostatic, depending on how the compensatory mechanisms go, right? So intra-event, that is during the less than 1 minute of syncope, what happens?
So the patient becomes bradycardic,
Yeah.
hypotensive, there is pallor, and diaphoresis that is noted. But post-event, we have an entirely normal physical examination. That is to say the pallor, the diaphoresis have all resolved during that time. So we have a completely normal physical example. If any of these symptoms linger, we start to look for other possible causes of
so
syncope.
if we find a child that had a brief loss of consciousness, and then by the time we're examining, we find that there was injury on the tongue, it's very likely not to be syncope. It's very likely a seizure. Yeah. Okay. Fine.
So there are some triggers for vasovagal syncope, like anxiety or fright, like we mentioned,
fear of heights,
stage fright.
stage fright.
Yes, fear of heights, pain, sight of blood for some people.
Yeah, so we had in school then some of our seniors at the first sight of cadaver in anatomy lab, as soon as the body is exposed, some people collapse. Yeah, vasovagal, that's vasovagal syncope. Yeah, so it's important we identify these triggers. Yeah. Okay. So in a way, we are done with vasovagal syncope. We've talked about vasovagal syncope, which is the prototype of reflex syncope, right? We want to talk about orthostatic syncope now. So it's important we understand what is normal before we go to what is abnormal. What is normal when I get up? What are the physiologic responses when I stand up? And then what would happen, not me now, when somebody has orthostatic hypotension? So now when there is a sudden change in posture from maybe supine recumbent position to erect position, there is the effect of gravity that causes a sudden venous pooling of blood in the lower limbs and in the pelvis. So if blood pools because of gravity when someone is standing, then venous return is reduced. When venous return is reduced, stroke volume is reduced, and blood pressure is reduced. Now, because venous return is less, the diastolic filling of the left ventricle is less. So the stretch on the C fibers on the myocardium, that's the ventricular mechanoreceptors, less stress. So through a feedback mechanism, the stress is less. So the afferent neural input to the brainstem integrating center is also less. And when you have decreased stimulus, the response is that it will quickly trigger an increase in sympathetic output, right? So the sympathetic output goes to quickly increase the heart rate, increase the peripheral vascular resistance, so that blood pressure will come back to normal. Mind you, up here, when venous return reduced, stroke volume reduced, transiently blood pressure reduced. So when sympathetic output increases, the blood pressure comes back to what is usual. This is important we understand. So it forms a basis when we now discuss the abnormal physiology in orthostatic. So there is a quick cerebral autoregulation, and so that's why we do not feel it, because with the drop in venous return, stroke volume, and blood pressure when we get up, there is also transient decrease in cerebral perfusion, but our bodies are able to auto-regulate quickly. That's the cerebral auto-regulation.
So failure of our sympathetic system to pick up in this situation would cause orthostatic syncope or orthostatic hypotension. So there are actually different types of orthostatic hypotension. We have the initial, the classical, and the delayed.
So if you listen to the case we presented, we deliberately measured blood pressure in supine position. The adolescent was lying down for like 5 minutes before we took pulse rate and blood pressure. Then we allowed him to stand up for like 3 minutes. We repeated the same thing. Now, in orthostatic hypotension, there is a drop in systolic blood pressure of greater than or equal to 20 millimeters mercury, or diastolic blood pressure greater than or equal to 10 millimeters mercury when the patient assumes an upright position, from supine to upright position. Now, the different types of orthostatic hypotension will have a lot to do with the time interval that it takes to achieve the drop in systolic and diastolic blood pressure. So the initial takes how long?
15 seconds.
15 seconds. So it can be that fast. 15 seconds is really short, brief, right? But if it takes up to 3 minutes, within the first 3 minutes, then it's a classic orthostatic hypotension. Now, if someone gets up abruptly, but it takes longer, more than 3 minutes for it to occur, then that is a delayed orthostatic hypotension. So we've talked about the normal physiology, that's a physiology. We've talked about the definition of orthostatic hypotension. So what exactly is the pathophysiology in orthostatic syncope? So in this case, there's a sudden drop in venous return that we know when we get up, right? In this case, normally, when there is a decrease in venous return, the diastolic filling is less, so there's less blood going out. But the pathophysiology here is the decrease switches to an increased ventricular contraction. So the ventricles are trying to contract quickly. So there's an activation of the left ventricular mechanoreceptors. This increases the afferent neural input to the integrating center. So because the input is much, then the sympathetic output will be less. Unlike what happens in normal physiology. In the physiologic situation, the stretch is less. The message being sent to the brain is less. So the brain acts by increasing sympathetic output. But in this case, there is that unusual contraction. So the impulse to the brain is more, and then the sympathetic output. Okay, fine. So someone has asked a question: How do you distinguish between prodromal symptoms and the aura of impending seizure attack? So we'll get to know this as we progress, right? We'll get to know this as we progress. The most important thing here, prodromal symptoms occur because there is hypoperfusion. So the cerebral auto, there's hypoperfusion in the brain circulation. So those dizziness, those prodromal symptoms, basically, you know, they are for the vasovagal.
Yeah.
Basically for vasovagal. So it's transient. For aura, it's coming because it is an impulse from the cortical neurons. They are still different. Yeah. Okay, fine. So we said that in orthostatic syncope, there is a fall in sympathetic activity. Now, if sympathetic activity is less, then the venous return reduces. If cardiac output is equal to stroke volume and heart rate, and the blood pressure is equal to cardiac output and total peripheral resistance, blood pressure ultimately drops. So we have a drop in venous return, ultimately leading to a drop in blood pressure. Unlike what happens in normal situations where a drop in venous return should reflexively trigger an increase back to what is supposed to be. In this situation, it follows through, right? So the person has orthostatic hypotension. Okay. All right, good. So there is a prodrome there.
Yes. So orthostatic hypotension also has a prodrome, just like vasovagal syncope, but the only symptom we're having is lightheadedness.
And it could be is usually minimal.
Yes.
Unlike the classic what occurs normally in vasovagal, usually minimal, or it could even be absent. It depending on how abrupt the onset of the orthostatic hypotension was. So if we have the early, we discussed the different types. We have the initial. So the initial one is more likely to have the prodrome.
Yes.
The more delayed it takes, the more adjusted, and so it may not be there. So intra-event is...
So we do not have any lingering symptoms during intra-events.
Yeah.
It just happens suddenly.
Yes. Okay.
And then there are some triggers. Yes, there are some triggers that can make
cause orthostatic hypotension. And these are important when taking history.
Yes.
Yeah.
Like the use of some medications like calcium channel blockers.
These are all antihypertensives.
Yes, antihypertensives.
So antihypertensives are acting to reduce the blood pressure. Yes. So if the reduction is so much, it will have this.
Also, the hydration status of a patient, diuretics.
Yeah, someone on excessive diuresis.
Yes. And hemorrhage, prolonged bed rest, prolonged standing, and also Guillain-Barré.
Yes, yes, where there is affectation of the innervation,
yes.
Autonomic dysfunction. Yeah. Okay, fine. So far we've discussed two categories of syncopal events: the reflex syncope and the orthostatic syncope. The reflex syncope, we have vasovagal as a classical example. We have situational syncope and then the carotid sinus syncope. Now, one thing there in reflex syncope is that there is parasympathetic overdrive. There is parasympathetic overdrive. Now, the problem in reflex syncope is that there's failure of regulating the drop in blood pressure, in venous return. And we said when we looked at our slide, so I said there's a slide that we must pay attention. So I'll go back to that slide just to emphasize. I said this overview of syncopal mechanisms, will bear it in mind. We said the reflex syncope, we said maybe if it's a vasovagal, fright, sight of blood, a sudden anxiety is sending the message from the brain, oh, I don't like what I have seen or experiencing, and then makes the vagus nerve go to cause effect on this central cardiovascular system. In orthostatic is simple, drop in venous return. Now we want to talk about the cardiogenic syncope. Now this is most times bad. Cardiogenic syncope is bad, and so we want to pay attention to cardiogenic syncope. Good. So broadly speaking, there are three types, right?
Yeah. So we have the arrhythmias, the
Yeah.
structural lesions, and the functional lesions.
Yeah, so some people say arrhythmias and mechanical. So structural and functional could as well be said to be mechanical. But for ease of flow, we said arrhythmias, structural lesions, functional lesions. Yeah.
So for the arrhythmias, we have syndromes like long QT syndrome, we have the Brugada syndrome, Wolff-Parkinson-White syndrome, that's the pre-excitation syndrome. We have tachyarrhythmias.
Yeah, so just to make us know, we find the heart, this heart that is contracting here, having its own tachyarrhythmias, right? So there's tachyarrhythmia or bradyarrhythmias. Now, if sinus bradycardia is usually of not a problem, right? Usually, but if everything is ruled out and there is syncope attached, then it's a bradyarrhythmia that is significant. Now, asystole on the ECG strip is flat. There is a problem. Complete heart block, because there's a type 1, type 2, type 3, there is complete AV dissociation, atrioventricular dissociation. So the complete heart block can lead to Stokes-Adams syndrome, where because of the block, there is a dissociation, and so cardiac output can drop so badly transiently, and the person blackens out, gets into faints, or gets a syncopal attack. So that's Stokes-Adams syndrome related to complete heart block. But some of our patients are on pacemakers, right? So by the way, a lot of interventional procedures will soon start in cardio care for even children. Already, these are pacemaker implantation is done commonly for adults in our hospital, but plans are on the way to commence for pediatrics. So if you find an adult, an adolescent, or a child with a pacemaker that is malfunctioning, it's now causing bradyarrhythmias. That child can have a syncopal attack from arrhythmias, which is a cardiogenic cause of syncope. We will look at some of the arrhythmias in brief so that it will be easy for us to follow. So under the structural lesions, it's important that we've just simplified it. It's either there's an obstruction to the left ventricular inflow, right? Yeah, so there's an obstruction to the inflow, or there's an obstruction to the outflow. If anything blocks filling of the ventricles, it can ultimately lead to decreased cardiac output. If anything blocks the outflow, it can ultimately lead to decrease in cardiac output. Now, decrease in cardiac output is the underlying factor for all these types of symptoms, right? Good. So if we have an aortic stenosis, then cardiac output drops. If we have pulmonary stenosis, which is the right ventricular outflow tract, if there is hypertrophic cardiomyopathy, hypertrophic obstructive cardiomyopathy, where there is asymmetric septal hypertrophy, it can also block the outflow of the left ventricle. Now, for inflow, if there is a mitral stenosis, so the mitral valve is a left atrioventricular valve. If it becomes stenosed, it's not giving space for diastolic filling. So if left ventricular filling is less, then the cardiac output is less, and the patient can have a syncope, right? Now, tamponade, we've released a lot of cardiac tamponade, and that has saved the children. So one that I relieved was that the child had a lot of fluid, like up to 2 liters in the pericardial space. Cardiac tamponade, so pericardial effusion is bad enough. Now, cardiac tamponade is compressing the heart all around, circumferential. In that instance, there is no space for the left ventricle to dilate, to become filled during the filling phase of the cardiac cycle. If the heart does not fill up, it will not pump enough. If it doesn't pump enough, it's decreased cardiac output, which will ultimately cause syncope. Yeah, so that's for the structural. Now for the functional. In functional, okay, let's say dilated cardiomyopathy. In dilated cardiomyopathy, there's global hypokinesia. The heart is just contracting very weakly, very weakly. So it's not pumping out enough, right? So it's a problem. So also in hypertrophic cardiomyopathy, in that case, is disorganized. The way the contraction is, the ventricular and the septal diameter size is thickness so wide, so it's functionally not filled enough, and so functionally it's not supplying enough. Even arrhythmogenic right ventricular dysplasia. Now, mitral valve prolapse. Mitral valve prolapse is notorious. You see, mitral stenosis will cause an obstruction to inflow. So mitral stenosis obstructs inflow of the left ventricle. But mitral valve prolapse, the ventricle will fill up. So the ventricle will fill up. But at the ejection phase of the cardiac cycle, when the heart contracts, normally we should have an anterograde flow. That is, it's moving from the left ventricle to the aortic root to go out. But if there is an incompetence of the mitral valve, the ventricle contracts, blood goes front and back. So there is anterograde, there is retrograde. That retrograde percentage reduces the cardiac output, so there can be syncope. Yeah, so.
Okay, so for the arrhythmias, we have long QT syndrome, which is a disorder of myocardial repolarization, which basically prolongs the QT interval.
Yeah, so we know that if we review the basic ECG strip, the P wave is the atrial response, by depolarization when the sinoatrial node sends its, fires. So there's atrial depolarization. Now, it is conducted to the ventricular myocytes, and then the ventricles depolarize. When the ventricles depolarize, between the ST segment, the ventricles are trying to repolarize. Now, the wave that captures the complete ventricular repolarization is the T wave. So if the interval between commencement of ventricular depolarization and the end of ventricular repolarization, if it is prolonged, then we said there is a disorder in myocardial repolarization. As we can see in the diagram below, the QT interval is longer than what it should be. We will see the next slide, we'll talk of show the classical ECG finding in long QT syndrome. But what's the problem in long QT syndrome here? Yeah, so the fact that when the QT interval is too long, it can degenerate. So just like a child has fever, the fever is high grade, it can degenerate to convulsion. Yeah, so the arrhythmia here, the QT interval is too long, and it now degenerates to a polymorphic ventricular tachycardia of the Torsades de Pontis variant, where it's like the ECG finding as if it's twisting around the point. So the problem with long QT syndrome is these patients can have sudden death from this Torsades de Pontis. Yes. Okay, fine. So we have the clean ECG tracing, which cannot be missed. This ECG tracing cannot be missed in a child with a child, adolescent, or whoever that has long QT syndrome. Now let's look at the rhythm strip ECG lead 2, or in fact V5. We've simplified it by placing our mark on it. The QT interval starts from the beginning of the Q wave to the end of the T wave. Now, see where the T wave is ending. So this entire length is a QT interval. Now, when the heart rate is fast, you can calculate the QT interval using the Bazet formula. But let's see. We want to make the presentation as simple as it should be, right? Normally, the QT interval should be less than half of the RR interval. So this is an R wave, this is another R wave, and this is a QT interval. I mean, the QT interval here is almost 2/3. Pick anyone randomly. Let's go here, away from where we marked. Just pick this. This is a RR interval, and we have the QT interval starting from here till where they just at this point. So the QT interval is just way too long. If this is identified on time and addressed, it will prevent degeneration, deterioration to the ventricular, polymorphic ventricular tachycardia that can lead to sudden death. Yeah. All right. Good.
So long QT syndrome has two clinical phenotypes.
Yes. So long QT syndrome can be acquired or congenital.
Yeah.
So we are dealing with congenital just for now. So yeah, this is a congenital.
Congenital phenotype, yes. So we have the Roman-Ward syndrome, which is the one that we see more often.
Yeah, it's common.
It is autosomal dominant, and it is purely cardiac. But when we're having some associated sensorineural deafness, we can associate it with a syndrome called Javel and Lange-Nielsen syndrome, which is autosomal recessive, and it is known to run a more malignant course.
Yeah. Syndrome is very straightforward. Just know that know where the RR interval is. Start from where the Q wave begins to where the T wave ends. You realize that it's more than half of the RR interval. I think that's very, very simple. If I find this, the next question is, do we have a nerve sensorineural deafness? Does we have an auditory pathology in the child? If the answer is yes, it is a more dangerous variant. Yes. Okay. Yeah, so welcome to Brugada syndrome. We said that cardiogenic syncope can be because of arrhythmias. Now, because in the excitable tissues of the heart, we know that sodium influx commences even in the excitable tissues, the pre-potentials, the early phases, right? Now, if there is a pathology with the channels, the sodium channels, called a channelopathy. So, an autosomal dominant arrhythmogenic channelopathy of affecting sodium influx is a problem that occurs in Brugada syndrome. The problem is there is high risk of sudden cardiac death. Again, just like in long QT syndrome, is because of ventricular tachyarrhythmias. Right. Now, ventricular tachyarrhythmias that occur during sleep, you think a lot of Brugada syndrome, right? We will look at the one that occurs during activity more, but note this. So at a certain age, these adolescents died during sleep. And there was history that somebody in the family tree died around this age during sleep. Now, village people are at work, right? Maybe true, but we can explain it with the arrhythmogenic channelopathy that we are talking about here. So most syncope take place at rest for these people, and there's usually family history of sudden death. All right. So what is the ECG feature here? We will look at this ECG tracing now. Now, just like the long QT syndrome was easy to identify, look at V1, look at V2. The problem here is that there is a rise. Yeah, ST segment is elevated. So you see, this is a S wave, and this is the isoelectric line. So the TP line, the normal, just this straight line is the isoelectric line. The problem is the ST segment goes so high, and on the precordial limb leads, if it's above 2 small squares, then is ST segment elevated. Now we have it involving 3 small squares, right? So 3 small squares, so it's pure ST segment elevation. And with the J leaf, the junction there. Now we have an ST segment elevation, which is convex upwards. See the arrow pointing is convex upwards. If that is what is there alone, that does not complete the diagnosis of Brugada. But with the elevated ST segment, there is an inverse, so the T wave is inverted. So there is the elevation of the ST segment with a mirror image of the T wave being inverted. So this is classical of Brugada. Now, but there are 2 types of Brugada, and we shall see the way the ST segment occurs. But one thing that is common in the 2 types is that ST segment is elevated, and the T wave following the elevated ST segment is inverted. Yeah.
So Brugada can be Brugada pattern and Brugada syndrome.
Yes.
Basically, the ECG features are okay. We'll get to that. We have 2 different ECG tracings for Brugada, but there are typical ECG tracings for Brugada pattern and Brugada syndrome.
Yeah.
But in Brugada syndrome, the patient must have experienced a sudden cardiac arrest or cardiac death, or we have a documented sustained ventricular tachyarrhythmia. That is an ongoing ECG tracing.
Yeah. So the Brugada pattern is based on the ECG pattern. Just that's enough. But if there is an ECG pattern plus history of sudden cardiac arrest. Now, when they say history of sudden cardiac death, then this diagnosis is made in retrospect. So it's a post-mortem diagnosis. So if we have a patient with Brugada pattern that has lived a normal life, but the person died suddenly, that automatically qualifies for Brugada syndrome. So why the ECG is important is that, oh, this is Brugada pattern, close watch, right? Good, that's it. Okay, so these are the ECG patterns that we have. I have first of all described the first one that would have a convex upward ST segment elevation and then an inverted T wave that follows almost immediately. That is type 1 Brugada ECG pattern. Now, the type 2 Brugada ECG pattern is truly, there is actually that elevation of ST segment, but there is a saddle shape, it drops. So this is the isoelectric line. This is the isoelectric line, and the ST segment is actually elevated. But just briefly, the T wave gets inverted. So yeah, so that's making it biphasic. So in this case, the ST segment descends towards the baseline and then rises again to a biphasic or upright T wave. So when the T wave is upright, is biphasic, right? And this gives a saddle shape. When the T wave is inverted, as in type 1 Brugada, there is an elevation of the ST segment. So this should be very clear. Convex upwards, inverted T wave, you have type 1, right? ST segment elevated, saddle shape, upright T wave, biphasic T wave, type 2 Brugada ECG pattern. I think this should rest the case of the types of Brugada. Yeah.
So we have hypertrophic cardiomyopathy, which can be both functional and structural.
Yes. So why is hypertrophic cardiomyopathy both structural and functional? It is structural because the structural asymmetry of the interventricular septum alone can cause obstruction of the left ventricular outflow tract. So that's structural. It is functional also because the hypertrophy of the interventricular septum and the left ventricular posterior wall decreases the volume of blood that it can get in diastole. So when it is pushing out the blood is just too little. So yeah, cardiac output is reduced. Now, sorry, let's go back and see something. I want to highlight something. Brugada syndrome, high risk of sudden cardiac death during sleep. Good. Now let's go to hypertrophic cardiomyopathy during exercise, during exertion. So it's important we bear this in mind. The person had syncope during sleep. The person had sudden cardiac death. Syncope that led to sudden cardiac death during sleep, right? More likely Brugada. Syncope that led to sudden cardiac death during exercise. You think of hypertrophic cardiomyopathy. Yeah. Okay. Yeah, so we have the echo image and the ECG image here of hypertrophic cardiomyopathy. We see that the interventricular septum is more than twice the expected thickness. It's just too thick, right? We see the left ventricle chamber just too little. In fact, if you do not understand echo images, look at left atrium. How on earth can left atrium have a larger size than left ventricle? But this is what occurs in hypertrophic cardiomyopathy. Now look at the atrial wall, slim, right? Now look at the ventricular wall, very thick. The ventricular wall, very thick. The interventricular septum, also very thick. So structurally, this thickness of the interventricular septum obstructs the left ventricular outflow tract, and then this fact that the capacity, the size of the chamber is reduced, functionally affects it. The voltages on the left precordial leads are just too elevated and classic of a left ventricular hypertrophy on ECG. Good. So we just looked at hypertrophic cardiomyopathy. Now, this is dilated cardiomyopathy. This is a real case. This is one of our echoes that I just screenshot and used for this presentation. You see how the chambers are so big. The right ventricular chamber, the left ventricular chamber, right atrium. So we call this a globular heart. The heart is globular, large, right? Now, the heart should be contracting, just contracting. But in dilated cardiomyopathy is enlarged and hypokinetic. So it's just contracting barely. How do you get to know? Look at the ejection fraction here, 24. This was really, really bad. Yeah, so we had to place on inotropes to get this girl out of this. It was a 5-year-old girl to get. So ejection fraction 20. This ejection fraction is less than half of physiologic one. So when it's so bad like this, you have to place a child on aspirin, you have to place on inotropes. Aspirin because blood can start clotting, because blood should not be stagnant. There's stasis here. There is stasis. So we expect that normally we're expecting like 55% and above. But here we have just 25 in a child that the chambers are so enlarged. So that is dilated cardiomyopathy. Simple. The blood, there's venous return, right? But it's not pumping enough. So the cardiac output is not meeting up with the physiologic demand. The child can throw up a stroke, a syncopal attack. By the way, they're also prone to arrhythmias. So it's a functional problem that can have superimposed arrhythmias that can cause syncopal events. Good. We have talked about the 3 broad types of arrhythmias. Sorry, the 3 broad types of syncopal attacks, right? Now, because the transient complete loss of consciousness can occur even in other clinical diagnoses, and even among the class of syncope, we have different types. We've come up with this algorithm so that if we have a child in front of us that has syncope, transient loss of consciousness, we'll be able to, with elimination method, identify with a high level of precision what it should be.
So it's based on the symptoms that the presenting what we see clinically. So if the child came with migraine-like headaches, or there was a history of postictal states, like or there was incontinence or prolonged loss of consciousness, we would say if there was put seizures, migraines, or CNS lesions in our differentials.
Yeah.
If no,
Yeah.
if we have an ECG pattern and it's okay, or we have an abnormal CVS
Examination
examination
for
finding, like
example,
a
murmur,
yeah,
a murmur or irregular heartbeat.
yeah, or irregular heartbeats, then it's maybe a cardiogenic syncope.
Mm.
But if not, and we're having history of abnormal cardiovascular system
Yeah.
history,
Like palpitation.
yes, like palpitations,
Yeah.
or
any other cardiovascular
Yeah.
symptom. Yeah.
yes.
So
If still yes, then we'll still rule it out as a cardiogenic syncope.
yeah, so a little again on cardiogenic syncope. You see, cardiogenic syncope stands on two legs here.
Yes.
So it could be a yes
Based on-
to abnormal CVS exam or abnormal history, or a yes to abnormal history. So exam ECG, yes, cardiogenic syncope. Abnormal history, yes, cardiogenic syncope. But if there is no abnormal, so if we ruled out all these, and there is nothing abnormal in the cardiovascular examination and cardiovascular history, you check. Do we have abnormal random blood sugar? Do we have abnormal PCV? Do we have abnormal positive urine human chorionic gonadotropin? If it is yes, for adolescent girls, pregnancy can cause syncope. It's important to know. So hypoglycemia, anemia can also cause it. Yeah. So in the event that all these are normal, right? So there is no abnormal CVS exam. No, it's okay. It's okay. There is no abnormal CVS exam. Okay, no, it's frozen. There's no abnormal CVS exam. There's no abnormal CVS history. Investigations so far are normal. Then we now ask ourselves, are we having orthostatic changes when the patient moves from recumbent posture to erect posture? What happens to the heart rate? What happens to the blood pressure in assuming upright posture? This is important for us to check. Good. So if we have a drop in systolic blood pressure or diastolic blood pressure, yes to it, you're thinking of an orthostatic hypotension, right? But if on assuming that posture, there is no, we don't have any findings suggestive of orthostatic hypotension, then we go on to ask, do we have history of toxin ingestion, drug injection, toxin injection, drugs of abuse? If yes, then we are thinking of a toxin-related syncope. If no, we are asking again, do we have abnormal respiratory pattern? If there's an abnormal respiratory pattern, yes to it, then we are thinking of, are we dealing with a breath holding spell? Are we dealing with hyperventilation? If no to all what we've been asking today, we check, do we have prodromal symptoms? Because prodromes are commoner in vasovagal syncope, right? Now, after we have ruled out everything, very likely we are dealing with a conversion disorder. So by way of this emergency evaluation, we've attempted to touch the various differentials of transient loss of consciousness. I hope we still remember the clinical scenario painted, which was a real case that we saw in clinic. If we go back, we said that child had headaches.
Yes.
Right? That child had headaches. So are we considering something in the CNS? Food for thought, we'll come back to it. The cardiovascular examination findings were normal. ECG was normal. But he had an abnormal CVS history, precordial pain.
Yeah.
So with precordial pain, is it possible the child had a cardiogenic syncope? Well, investigations were normal. We did check for orthostatic changes. which was not convincing. So, well, I've already answered it. I wanted us to get to know whether it's convincing or not. We were not very certain about toxin injection because that history was guarded. It was not forthcoming. Could we be dealing with drug abuse related? We have the history that the child does not like the boarding school where he was. Could we be dealing with conversion disorder? We'll look at it when we get back to the clinical case. How do we evaluate syncope?
So the goal in evaluating syncope is to rule out the more sinister causes of syncope, like underlying heart disease, and identifying high-risk patients. So family history is also very important in that. And while taking the history, we should keep in mind there's always recourse bias and amnesia, because the patient may not remember what happened.
I mean, they were unconscious, so
they had transient loss of it. So at the time of the event, so a need for eyewitness is also very important while getting history.
Yeah. So still on history, we want to see when we are taking the history. So some components must be present for a complete history. One, what was the position assumed as at the time there was the flaccid drop, right? The transient loss of consciousness with loss of postural tone. Reflex syncope usually occurs while standing, right? Yeah. So, but it can occur while sitting and even supine. Remember, reflex syncope of the vasovagal variant has a trigger. The trigger can be fear of height, which you may not necessarily be standing, you may be sitting when it happens, or sight of blood. You may see blood when you are lying down. It can still cause reflex syncope of the vasovagal type. Yeah, fine.
So what was the patient doing at the time of syncope? Was he doing something strenuous? Was there exertion? That strongly suggests it's cardiogenic, but if it's post-exercise syncope, we usually associate it with vasovagal syncope.
Yes.
And the presence of prodrome or lack thereof, presence of prodrome, vasovagal syncope.
Yeah.
Some cardiogenic syncopes may present with prodrome, but we usually mostly see it in vasovagal syncope.
Yeah. So how did the patient fall? How did the patient fall? So a flaccid fall without neurologic impairment is against seizures, right? Because they lose tone, they lose postural tone, so they are flaccid. Every other type of seizure will not be flaccid, apart from the atonic seizure, the drop attacks, right? Apart from that type, there would be that flaccid drop. Yeah. Okay, so post-syncopal event, usually there's complete loss of return of the loss of consciousness. Note that if there are post-ictal states, you think of seizure, right? So back to the question that was asked initially, how do you distinguish between prodromal symptoms and an impending aura? Usually for seizures, there will be that history. Seizure is one of the components of, so it's just one out of the neurologic abnormalities that the child could have. Then in addition, whereas most other seizures will have a post-ictal state, the syncope will not have it. Yeah. Okay, fine. So we want to see, we have our previous algorithm talked about how to differentiate the various causes of transient loss of consciousness and attempted to touch on the different types of syncope. Now, if we are sure it was syncope, then how do we diagnose? How do we make a diagnosis that, oh, this is this type of syncope and not this, right? So we go through this algorithm together. Every child, every adolescent that has syncopal attack must have orthostatic vitals checked, must have a 12-lead ECG done. So ECG must be done if you can identify the abnormal reading, fine. Now, for you to have registered for this webinar, you would get these slides. And the good thing is that we have a WhatsApp group for the cardiovascular, for our symposium, for which if you are in the WhatsApp group, an abnormal ECG you get can be sent to the WhatsApp group. We can quickly interpret in less than 24 hours. But the point is, ECG must be done. ECG should be done. No matter how convinced you are otherwise, get ECG done, do orthostatic vitals. Now, if so the patient is supine for like 5 minutes and gets up. Now, within 3 minutes, check the blood pressure. Was there a greater than 20 millimeters mercury drop in systolic blood pressure? If it's there, you are thinking of orthostatic hypotension, or a greater than 10 millimeter mercury drop in diastolic blood pressure, then you are thinking about orthostatic. Well, the heart rate issues are not as strongly predictive as the blood pressure ones. Now, if you find that you are thinking of orthostatic, now you now come to the ECG tracing. If the ECG is abnormal, just think of a cardiogenic syncope immediately. The next thing is which type of cardiogenic syncope. Is it due to a bradyarrhythmia, like a complete heart block that would have caused a Stokes-Adams syndrome because of the complete AV dissociation, the block in cardiac output, the reduction in cerebral perfusion, and then the syncope? Well, so we'll continue.
I think the mic is
Can we continue? Okay, fine. So sorry, there is a transient loss of consciousness of electric supply, but we did not suffer any form of vasovagal syncope, and so we are continuing the presentation. We want to be sure if you can hear us. Can you just put in the Q&A section? Yes, okay, fine, we are back. So it was actually a transient complete loss of electricity supply, which is like an arrhythmogenic type, right? Good, so we are back. So if the ECG is abnormal, just think of cardiogenic syncope. Now, ECG may be normal, right? ECG may be normal. If ECG is normal, rule out a mechanical cause, which we said either an left ventricular inflow, left ventricular outflow, or you think of any of the functional pathologies, right? Or arrhythmias can be occult, arrhythmias can be hidden, right? So if we have, so to rule out an occult arrhythmia, we do Holter monitoring. So Holter monitoring will get the ECG tracing over at least 24-hour period and pick up the occult arrhythmia. Then we do echocardiogram. So the echo will pick up the structural lesion, the mechanical lesion, the functional lesion that is causing the cardiogenic syncope. So far, we've said all syncopes, you must check orthostatic vitals, you must check ECG. Now, let's assume that orthostatic vitals are normal, the ECG is normal. Well, are we dealing with a reflex type of syncope? Now, we know that there are 3 types of reflex syncopes. 1, the vasovagal, 2, the situational, and then the carotid sinus hypersensitivity. So, you can easily check the carotid sinus hypersensitivity by a carotid massage. Yes, so that can be done. So a carotid massage, if there is a drop in systolic blood pressure of greater than 50 millimeters, so that's a rapid drop, the carotid sinus is just too sensitive, or there is an asystole of greater than 3 seconds, you are dealing with a carotid sinus hyperactivity. But if that is negative, you want to ask yourself, this reflex syncope has a prodrome. There is prodrome plus a recurrent situational activity, right? There is a prodrome plus syncope occurring when this person is coughing. It's a situational syncope. Prodrome plus syncope occurring while the person is urinating is situational. Now, I would like to crack a joke. Question and answer, please. So let me be brave to ask our audience a question. Is it possible to have situational syncope in supine position, I want to know, is it possible? So we said we are suspecting a reflex syncope. There is prodrome, and this person coughs and has syncope. This person urinates and has syncope. In what situation may reflex syncope of situational type occur in supine position? There's a very funny answer. Let's see. Nobody is willing to get the gift. Okay, I'll quickly answer bedwetting and enuresis. So bedwetting, that's it. So if somebody bedwet, because usually the person will be in supine position, right? Person can be in supine, but just in that supine position, the person just finished bedwetting and the person is flaccid and there is loss of consciousness, right? That recovers immediately, right? That's situational. Well, I got the award myself, so just leave that for me. Now, so when there is prodrome and it's associated with an event that occurs, like maybe pain, oh, we want to set an IV line on an adolescent. So we have a lot of adolescent Gen Zs now who are like agibotas. So you apply the tourniquet at the site of needle just to penetrate the skin, they throw up a syncope, right? So there's prodrome and there is syncope identifiable with a trigger like pain, phobia, or even prolonged standing. That is more likely a vasovagal syncope. Now I have a question. Nobody answered my first, none of our listeners answered my first question. I have a second question. We talked about orthostatic hypotension occurring when somebody stands up. We are now saying prolonged standing can cause reflex syncope. Why? Are we not mixing things up? Why? I know everybody will understand phobia. There is a prodrome like dizziness. There is a prodrome like a transient blackout because retinal blood supply drops, right? But it's occurring when somebody is standing for long. What is the difference between the standing here, that is a vasovagal syncope, and the standing here, that is an orthostatic syncope? Jump question. Difficult question. I will collect my award again if we don't get an answer. Fastest fingers. I will answer my question so that I'll collect the award. In this case, the person is standing. The person has adjusted the normal auto-regulation that occurs when somebody moves to upright position has already occurred. But there is a problem with the prolonged vagal discharge. Remember that in reflex syncope, the problem is vagal stimulation, right? The vagal, the parasympathetic stimulation. Everything in reflex syncope is parasympathetic. In orthostatic is failure of the sympathetic. So that's it. Now, if we say vasovagal syncope, how then do we confirm? We want to check further, right? You can obtain a tilt table test if you are unsure of the history. History is not clear and you are trying to do a tilt table test. Good.
Okay, so a tilt table test is basically to confirm vasovagal type of syncope. So we place the patient in supine position on the table for 10 minutes while checking the pulse rate, the blood pressure, and maybe symptom, asking the patient, oh, are you feeling dizzy now, lightheaded? Prodrome symptoms basically every 5 minutes. And then that's for the supine position. Then the next step is we tilt the table up to a 70-degree angle. And for 25 minutes. And then we check for the pulse rate, the blood pressure, and we keep asking if they're feeling any prodrome symptoms, they will let us know.
So you see, that tilt is sudden. That tilt is sudden. So there is effect of gravity at that tilt now. So there is pulling of blood backwards down. If there is failure of autoregulation, it can produce hypotension and syncope of the orthostatic variant if the person has problem with autoregulation, right? But if the person is prolonged in a prolonged tilt and there is now increased firing of vagal impulses, and then one is now feeling it in canal. So when it's tilted, it doesn't give the symptoms of syncope. We can, because the patient has an IV access, we can instill isoproterenol while taking the symptoms. Yeah, fine. So there's a basogeric reflex in physiology, if you remember, where isoproterenol is infused and then these abnormal physiologic signs occur. That's for the simple head-up tilt table test. Good.
So for the management of syncope, it depends on what type of syncope we're dealing with. So for the management of vasovagal syncope, when we have when we're just outside and someone faints, what do we do first? We leave the person in supine position because people try to bring the person up.
That is
gather around
so people have an abnormal reflex. So when the patient has, let's say, a reflex syncope and has collapsed, those who are healthy now have an abnormal brain reflex of trying to bring the person up. Now that is totally wrong, right? The person is supposed to be left in supine position so that the effect of gravity is less and circulation resolves. The syncope is transient. The person will get out of it.
Yes. So cerebral perfusion comes back and patient is fine. But there are some prophylaxis we can give to avoid syncope happening. We can give some alpha adrenergic agonists, some beta blockers, selective serotonin inhibitors, and so on.
Yeah, so anticholinergic. Remember that the vagus nerve, the neurotransmitter that the vagus nerve is going to release is acetylcholine. Yeah, so the vagus nerve causes its cardiodepressant effect through acetylcholine at the muscarinic receptors. So you want to give anticholinergic blockers. So you block that effect. So the person is going to live a happier, healthier life, right? So volume expansion also would help. So for orthostatic, yes, also like vasovagal, let the person be in supine position. If for all of the syncopes, don't rush to get the person out of supine position. But because it's a problem of gravity and disordered autoregulation, you want to use things like elastic stockings, high salt diet, corticosteroids to help, right? So if it is known to occur quite frequently, I mean, let the person rise up from sitting or supine position slowly. You mustn't get up abruptly. Yeah. So for the cardiogenic, we see that cardiogenic syncope, they are different types, right? It could be because of arrhythmia. It could be because there is an inflow obstruction, an outflow obstruction, or a functional pathology. So it is targeted towards what? So for example, it would be surgery if there is mitral valve pathology. So a mitral valve prolapse, we said is functional. So mitral valve prolapse is structural pathology, but it causes syncope through a functional pathway because at the ejection phase of cardiac cycle, there is anterograde flow and there's a retrograde flow, so decreasing the eventual total flow from the left ventricle. So surgery can fix that. Well, catheter repair for dilatation for mitral stenosis also, or valve replacement surgeries. In Wolff Parkinson White, there's an aberrant pathway firing unusual, so ablation can take care of that. So long QT syndrome, we know that you can give beta blockers, pacemakers, or implantable cardioverter defibrillators. Why do we implant defibrillators? We said that long QT syndrome can degenerate to polymorphic ventricular tachycardia. right, which is shockable. So you implant that, so you cause for defibrillation. Well, for other arrhythmias, you give anti-arrhythmic medications. Yeah. Okay, so back to our case. So please, dear audience, I have asked several questions and I have answered the questions myself. So let's walk ourselves through and see if we can interact a little, because we are coming to the end of our presentation. We appreciate your time, but let's work out it, because this patient actually came to our clinic. It's not fictitious. So a 15-year-old male SS1 boarding student, maybe nothing particular about that. Now, history of recurrent frontal headaches. So this is a red flag. There's headache already. So is that transient loss of consciousness actually syncope or something else? That's why we put this in red. I was treated for meningitis in another hospital where we don't nothing to hold strongly about. Had a fainting spell. Fainting spell was transient, right? So that is a transient loss of consciousness. It occurred while standing. There was a prodrome. So we are gathering a lot of evidence now. Now there's this background sharp left, that's precordial pain. This is a cardiovascular symptom, right? Now, history of sedatives or stimulants intake is vague. Probing was not successful. Now, further history reveals he does not like his school. So we've looked at this history. Let's look at the examination findings. He was supine for 5 minutes and we took the pulse rate, 94 beats per minute. It was regular, that was good. Blood pressure measured at the right arm in supine position was 110/78 millimeters of mercury. Now let's check. Do we have a difference of greater than or equal to 20 millimeters of mercury systolic? No, there is a drop of 10 millimeters systolic. This does not meet the American Autonomic Society criteria for autonomic for orthostatic hypotension. Now look at the diastolic. There is a drop quite well, but it's a drop of 8 millimeters mercury. Still, it does not reach the criteria. So on the basis of orthostatic symptoms, we cannot classify this patient as having orthostatic syncope. That is it. Now, but this patient felt dizzy while standing. And dizziness is pre-syncope, right? So what could this be? If we have a prodrome, but negative orthostatic symptoms, maybe we are dealing with a vasovagal syncope. Yeah. The central nervous system and respiratory system findings were normal. Investigations were normal. The question is, what can you make out of this real case? That is, what type of pathology were we dealing with? We have a host of them. What type of pathologies? So can we please get responses in the Q&A? Please let's know if we are firing well or giving arrhythmic discharges of stuff from our mouths. So let's know, what can you make out of this? Is it, what type of transient loss of consciousness? Was it a seizure? Is it really syncope? If it's syncope, what is it likely to be? Can we get responses in the Q&A to see what is going on? Perfect. So somebody said reflex syncope. That is very good. So we are getting responses. That's good. So reflex syncope, probably vasovagal. This is very, very specific. Good. In fact, the person went ahead to answer the next question. What more would you do for this patient? Yes, a head tilt test. Yeah, a head up tilt test. Yeah, so that's very good. Any other thing we just want to see? So let's see what more. What more? Could this possibly be something that was not a syncopal attack? If yes, what possibly could it have been? Were there other things we could have done that we did not do for this patient? We did cardiovascular examination in supine position. We did cardiovascular examination while standing. We did it for 3 minutes. Could we have done more? We just want to know. We did ECG, we did echo. Could we have done more? Let the answers roll. We'll soon start responding. We are getting close to the end of our presentation. All right, so let me look at, so we have some responses. Okay, perfect. Somebody said vasovagal syncope or a conversion disorder. Why conversion disorder? This person did not like the boarding house, boarding school. It's clear the person, because of bullying, does not like. So it could well be a conversion disorder. However, we will not make a diagnosis of conversion disorder and send them home. We want to check. So if you look at this case, something else that we could do, right? You could still keep the patient standing for greater than 3 minutes. Remember, we vasovagal syncope can be
classical, initial, classical, and prolonged.
So there's the initial. Answers are falling in. So this patient stood for just 3 minutes. Actually, we did longer. We did actually up to 10 minutes. But for the purpose of this presentation, so if we had a syncopal attack greater than 3 minutes, then it's delayed. Less than 3 minutes, it's what's classical. Then initial when it's so early. Now somebody said Holter monitoring. Yes, if ECG is normal with the history of chest pain, ECG normal, Holter monitoring could peak. So we are really excited at the number of participants that are holding forth. We are rounding up briefly, but before we conclude, we will just talk about the complications, and then there will be a brief announcement, right? So what are complications of syncope?
So complications of syncope are usually from the event itself, like the falling, like lacerations, fractures, head injuries, and then road traffic accidents too can happen in situational or vasovagal type of syncope. Even some cardiogenic, an arrhythmia happens while you're driving.
Yes. So adolescents that drive can shoot up a syncope if they have a primary cardiac pathology. Yes. Okay, fine. So we will give space for a brief announcement, and then we'll just wrap up. All right, so we will just wrap up at this point. Thank you. We said that for syncope, in conclusion, we have features that we should know if we are dealing with a reflex syncope. We have features that we should know if we are dealing with orthostatic syncope. We have features we should know if we are dealing with cardiogenic syncope.
Okay, so for reflex syncope, we usually have prodromes. And it's from it's a message from the brain with overdrive to this cardiovascular system. For orthostatic syncope, it's usually positional, so a change in position would cause the syncope, and it's usually a decreased venous return from the cardiovascular system to the brain. And finally, for cardiogenic syncope, it's due to decrease in cardiac output, and it's usually sudden, associated with arrhythmias or exertion. That's its mechanism.
Yes, yes. So if it's exertional, then it's mechanical, right? Do you remember? So please, dear audience, please, you must answer this last question before you go. Which type of cardiogenic syncope occur during sleep? That is the question. What type of cardiogenic syncope occurs during sleep? Which type occurs commonly during exertion? From our presentation today, let's see the fastest fingers. Let's see if we have answers. Which type of syncope occur? Somebody is sleeping and then has syncope and dies. All right, so let me check if we have answers. Yeah, perfect, perfect. So Brugada, sleep. Yes, so Brugada syndrome, syncope occurs at sleep. Hypertrophic obstructive cardiomyopathy during, so we have a lot. In fact, you should give yourself a virtual clap. You should give yourself, we are clapping for you from this end. Thank you, thanks a lot. You've been an exciting audience. May you not have syncope at all. Thank you.
Thank you for joining us.
Thank you for joining our presentation. If we wish you stand by briefly, we will just make a few announcements from our PR team.
Good afternoon, viewers. Good afternoon, viewers. My name is Green from the Corporate Relations Lead Strength of the team, and I'll be presenting on how we can refer and collaborate on the lead strength of the team. So, the lead strength of the team, they are located, lead strength of the team, an arm of the lead hospital, located at number 39 at Ademola is to Abuja, and the designated Center for Pediatrics. Our core specialties are into pediatrics generally, and our specialties include pediatric cardiology, neurology, speech and developmental clinic, all that. We have a robust neonatal intensive care unit. Like I mentioned earlier, our key specialties are pediatric dermatology, neurology, we do pediatric surgeries like for children with structural heart defects like ESD and ESD. So how to refer to us, you can give your patient the standard referral letter to us, or you can give us a call on our numbers. You can call us on 080 9599 94 or 9081841655. You can also reach us via WhatsApp on 0924296118 or via our email address that's childrenhospital@gmail.com, or you visit us at number 29 at Mother Court. And while referring, it's advisable for the doctors to take their details, like their names, email address, and also the numbers, so that we can also get back to you, because we do a standard referral back to the doctor so that they can have a full knowledge of what to do for their patients. I'm very much open to referrals for you. I hope to collaborate with you. Thank you.
All right. So we thank you for your nice comments. We are happy we had a good academic time with you all. We will still invite you for next month's session of the webinar from Limi Children's Hospital. It promises to be probably more exciting than that of today. But also our seniors, that is the adult physicians, will also make their own webinar in a short while. So you will get these adverts, and we just want to be sure that you had a good exchange for your time and data spent. Thank you. We are always happy to be with you academically and to collaborate to take care of patients when needed. Thank you.
The Limi Children's Hospital is a multi-specialty children's hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.